Hello, I'm Jim Watchorn. I'm an intensive care and medical registrar, and I'm going to present on two short presentations, one on volume status using echo and one on pericardium. So volume assessment is essentially done, like all echo, through your complete analysis or your complete assessment of all four views that you'll get. Because in order to do a full assessment of volume, you need to really assess both the left ventricle and the right ventricle, the IVC, and any third spaces such as the pericardium and the pleura, where over a long period of time you can get third space accumulation and things like chronic renal failure. So it's essential that you sort of, like you will do it with all your assessments, that you draw your conclusions at the end after you've looked at all of those various points. Having said that, echo it's a good crude tool to assess volume status. It doesn't pick up subtleties particularly well either with hypovolemia, but certainly with volume overload. It's not the most specific tool for it, but for the purposes of FICE, it will tell you whether the cause of your shock is due to hypovolemia, which is essentially, hopefully, why you're watching me talk today. So there's two main things that I want you to look at. One is the left ventricle and what the left ventricle is doing, and the other one is what the IVC, how big the IVC is, and what the IVC is doing throughout the respiratory cycle. So let's look initially at the left ventricle. Now, the left ventricle has one specific sign that comes relatively late in hypovolemia that's caused the kissing LV sign. And what happens is that it fills relatively well, but there's no pressure within the ventricle at the end of systole. So at end systole, the cavity almost obliterates and disappears, and you can see the walls of the left ventricle almost collapse in on each other. I'll show you that shortly. And then the second sign is what the IVC is doing, and later in the talk I'll show you a table really, and it just helps you make some assessment of volume status as you go on. So what you can see here is a cine clip of the parasternal short axis at the papillary muscle level, and that's when you do your echoes, that's the level I want you to check this at. So yeah, second to the fifth intercostal space, just turn the probe so the dot's pointing to the patient's left shoulder, and then just scan down, so you scan nicely through the papillary muscles. And what you can see, if you watch, the ventricle fills well, but as it comes towards the end of systole, the walls are collapsing and kissing. I'll caveat this with, if you've got a patient with left ventricular hypertrophy, this can be a sort of pathophysiological phenomenon that occurs in that state anyway, because they've got a relatively small cavity, so it doesn't take much for theirs to collapse. But in an otherwise healthy patient, if they're hypovolemic, you'll see the walls come in. This is, I wouldn't say it was a late sign, but it was sort of an intermediate sign. It's not a really early sign of hypovolemia, but it's one of the core signs that you need to look for with your echo. So this isn't the typical view, and what you should see here is a cine of the parasternal long axis. And I apologise for the fact that it's drifting in and out as the patient breathes. But again, what you can see at the end of systole, hopefully you can see that the inferior wall is coming up and almost touching the septum. And you'll also note, obviously, that the patient's hyperdynamic and relatively tachycardic, well, they're tachycardic at 130, which you don't need an echo probe to know that they will be hyperdynamic and tachycardic if they're hypovolemic, but you can see the effect it's having on the heart in this video clip. Again, this is another parasternal short axis of the same phenomenon. So you can see the heart sort of oscillating around in the image, and you can also see the walls of the LV almost collapsing. You could argue that this is at the mitral valve level rather than the papillary muscle level, but you can see what's going on. It's a relatively easy sign to spot. Apical full chamber. Again, very hyperdynamic. If you look at the free wall of the RV and the tricuspid annulus, you can see how much is coming up. It's not a specific sign of hypovolemia, but the hyperdynamism should draw your attention. There's some abnormality. And again, If the gain was a little bit higher, hopefully you can see the endocardial borders almost touching in this view. Now I'm going to talk about the IVC. So we've talked about the kissing papillary muscle sign. Yeah. Now we're going to talk about the IVC. So as you become more hypovolemic, as your venous system is the main capacitance system of your body, holding about 70% of your blood volume, as you become hypovolemic, it will have a major effect on how full, really, your venous system is, and it will start to collapse. And you can see that quite nicely with echo when you look at the IVC. So place the probe in the subcostal view, and you'll rotate the probe 90 degrees in an anti-clockwise rotation. I recommend when you look for the IVC, you find your standard subcostal view, swing the probe so the right atrium is in the middle of the screen, and then rotate your probe. And always try and keep the right atrium in the middle of the screen when you do the rotation, because in the same area is the descending aorta, and they look quite similar, but they're obviously different, and you can't do a volume assessment on the descending aorta. And only the IVC will empty into the right atrium, and therefore if you can see both, you can be sure you're assessing the right vessel. So as the patient breathes, they'll generate greater intrathoracic, or a lesser, more negative intrathoracic pressure, drawing blood through the IVC into the chest. As they become more hypovolemic, the reservoir of the IVC will have less blood in it, and therefore the walls will collapse faster. So to begin with, your IVC will just collapse a bit more in inspiration, and then eventually, as you become more hypovolemic, the walls will be collapsed throughout the respiratory cycle because there's not a lot of blood going around the system. This changes depending on how much inspiratory effort the patient makes. So obviously a big sniff in or a deep breath will draw more blood in, and you'll get greater variation than tidal breathing. So the chart I'll put up in a moment is for tidal breathing. It also changes depending on if your patient's being ventilated with positive pressure. And that's probably a talk for another day as to how you do a full volume assessment in these patients. But what I would say you could do from that is, on the same ventilatory pressures, you could do an assessment of the IVC, make some measurements. You could give a bolus of fluid if you thought they're hypovolemic, and you can make some more measurements, and you could see if their IVC is compliant and if they tolerated the fluid bolus from that. So I'm now going to play you the cine clip. So here is subcostal view. They don't have the right atrium in the middle of the screen for this view, but you can see the IVC through the middle, and the cursor's cutting straight through the IVC. So what you can see here, throughout the inspiratory cycle, the IVC is collapsed and it doesn't fill at all. So we've looked at the LV, we've looked at the IVC. There is a sign in the LV which looks at not the end systolic area. Remember I was talking about cavity obliteration and the small cavity in the walls collapsing, but it's the end diastolic area. Yeah? So that's when the LV is at its most full. And you can use this to assess for volume. It's not a very good sign, it is a sign, and it's a relatively late sign. So you can do parasternal short axis in the same view, pause, and trace the inside of the ventricle in the short axis and see how big the area is. And if it's less than 10 centimeters squared, then they've got significant hypovolemia. But it's, as I say, it's a relatively late sign, and end systole is better than end diastole in that assessment. Likewise, you can do the inverse to see if they're overloaded, and that should be greater than 20 if they are, but these are just the numbers, and most of the clinical studies would show that this doesn't stand up particularly robustly in critically ill patients. So this is just a still showing what you would trace round at the end of diastole, and you can see down at the bottom it's 13.3, which was within the normal range of 10 to 20. And then just going back over a few principles, looking at the IVC again, here you can see the variation of the IVC throughout the respiratory cycle. So this is a type of ultrasound called M-mode ultrasound, which hopefully you've come across already. Essentially, if you just imagine that everything along the cursor line is on the y-axis, and time is on the x-axis. It's a graph of the cursor line points as they move over time. So you can see that the cursor is bisecting the IVC, and then you can see over time the patient's breathing. If you look at the graph, you can see the swing of the IVC moving up and down as the diaphragm moves in and out. And you can see a variation or no significant variation there, 2.27 centimetres in A, which would be in inspiration, and 2.21 in expiration. So there's no significant change. So looking for volume overload, echo is not the best tool to do that, but you can see abnormalities. Be aware that all these abnormalities can all exist in other disease states. So if you've got chronic high right-sided pressures because you've got cor pulmonale, for example, they may cause the same changes as you would see if you had volume overload. What can you see? Well, I think long ultrasound is probably better, and you can see an abnormality in your A lines and B lines, but that's a talk for another day. And what you can see with echo is occasionally the RV becomes splintered and big. Occasionally the the septum becomes flattened and doesn't move and more fixed by the RV. And also as you go up, the interatrial septum can bow into the right atrium because your left atrial pressures are going up as well. So there is some signs, and obviously your IVC will change as a result. So this is a subcostal view looking at the IVC. You can see it's fixed and dilated as the patient's breathing. Thank you.